Our next speaker is Dr. Yamini MANIKTALA, and she's going to speak on neutrophilic dermatosis, unraveling the sweetness of a complex narrative.
Good afternoon, everyone. Shall I start?
Yeah, please start.
Yes.
Yeah. So I'll be presenting a case report of a patient of a 21-year-old female presented to the emergency services of ours with the right eye swelling, unable to open eye, and the swelling has been progressing over the last 2 days. On eliciting the history, there was no history of trauma or any insect bite, and the patient initially consulted elsewhere, diagnosed as necrotizing fasciitis, started on IV antibiotics, and then referred to our center. So on ocular examination, the visual acuity was 20/20 in both eye, EOM were full and free. Left eye was completely within normal limit, as well as the posterior segment was within normal limit. Whereas in the right eye, if you could see, there was a swelling which is involving the complete lid. It's a boggy swelling, which is erythematous surrounding is there and leading to mechanical ptosis. This was the presentation on day 1. When we see the same patient started on IV and oral antibiotics, this is the presentation on day 4 where the Ishar has formed, and as you can appreciate, the swelling has subsided to a lottal limit. And the presentation is more of indurated tender erythematous. Imaging was then ordered, and in the axial scans of anterior and mid-orbit scan, you can see that the soft tissue swelling is there in the right preseptal space, but there is no extension to the orbit, and the EOMs are normal. So a provisional diagnosis of necrotizing fasciitis was made at this time, and a decision was taken to debride this tissue under general anesthesia and also plan for microbiological and histopathological samples to be sent for further evaluation. So when the samples were taken, a very important thing was taken in mind that the tissue should be taken at the junction of involved and uninvolved. So when we get a histopathology report, we can appreciate what is the difference in the tissue. So this is the POD1 picture where open wound post-debridement was covered with a collagen sheet, which work as a biomaterial and give an environment for a healthy tissue growth, reducing the chances of scarring. Started on oral antibiotics at this stage and left for secondary wound healing. There was no progression on treatment. Patient was admitted at our center, and at this stage we have a microbiological report with us, and gram and QH was negative at this stage. This is the post 1 week image, and the microbiological culture reports also came out to be negative. We coordinated with the micro and histo to expedite the results, and we got the both results within 1 week. As you can see, that the wound healing with granulation tissue is there, and there are the involvement area has decreased from the initial presentation. So if on the histopathological findings, a surprise came to us that the presentation, if you see that there is a lymphocyte which is surrounding a ruptured blood vessel, and the presentation was more of a leukocytoclastic vasculitis with fibrinoid necrosis, predominantly with the neutrophils. So that made to a diagnosis, instead of necrotizing fasciitis, it to be more of a sweet syndrome, which is also called as a neutrophilic dermatosis. And a blood smear was also been requested, which came out to be normal as well, with no atypical cells is seen. So at this stage, a decision was taken to start oral tapering steroids according to the body weight. And this is the presentation from day 1 to POD 1 month, which has shown significantly improvement with no suturing or reconstruction being done, with limited scarring at POD 1 month. Patient kept on a follow-up till 6 months to us. So coming to our discussions, acute febrile neutrophilic dermatosis is a periocular sweet syndrome. It's a rare variant, and the immune response is basically getting exaggerated secondary to infection, drug reaction, and very importantly with the malignancies, autoimmune disorders like IBD. The classical sweet syndrome generally have a presentation of onset of painful erythematous plaques or nodules, and histopathological proven is being needed. And as I mentioned before, that the collagen sheet has been changes the surgical intervention and reduces the chance of a second surgery, because it's working as a biomaterial, which is helping in providing a more of a environment where more healthy granulation tissue will be there, recruitment of more fibroblasts and macrophages. So to differentiate the two cases, necrotizing versus sweet syndrome, the necrotizing patient generally presents with painful, deeper tissue involvement, and most importantly, having a systemic involvement, where steroids are contraindicated, whereas when we talk about sweets, steroid being the main treatment of choice. So the take-home message from my case is that it's a very close mimicker of necrotizing fasciitis, but to differentiate it, systemic involvement should be ruled out and inciting events should be confirmed, and diagnostic could be confirmed with the histopathology. Thank you.
Nice presentation. Any special reason why is this called a sweet syndrome?
What I read and when I go back to the history, the neutrophils, they have correlated with that. It's very predominantly with the neutrophils, and the scientist who discovered the person's name the second name was Sweets.
Okay, thank you.
So any predisposition for this syndrome?
Ma'am, the surprising thing in this case only that the patient doesn't have any malignancy or any inciting event involved with it, and that's why we choose this case, because all of the articles which we have been gone through or seen, always there is either some systemic involvement of malignancy or infections or a history of trauma. But she doesn't have any of it. All the investigations were done, and patient kept for a period of 6 months follow-up. Even told that if you find any signs later on in the body or any presentation, please come back to us and maintain on a teleconsultation. Now I guess it's been 9 months, but she doesn't have any other presentation.
Had you known about this sweet syndrome before?
No, this was the first case, and it was.
That's what I'm saying. Had you known that it is a sweet syndrome, so you think we shouldn't have done the debridement part as we do in NF? We should have directly given steroids?
We haven't given steroids directly, ma'am, in this patient because
because you were suspecting NF. You started
Yes,
the
yes.
treatment with NF, so you did the debridement regularly, and then you came to the
yes,
sweet
so
syndrome.
we had a discussion at our center with my.
Like the findings as you have told, no trauma, no systemic. If we come across any such patient next time, predisposing factors for NF and present like this, so do you think it is suggested that do not debride and just go ahead with steroids?
No, even if the presentation is like that, in 4 days the swelling has subsided, and there was no reason why Ishar is forming. So when Ishar is forming, it's more towards a question mark presentation that it could be necrotizing. We are missing on something, and steroids.
So I think debridement is a must in both the cases. Without
Yes.
debridement, the steroids also
It's a
would.
necrotic
Yes.
tissue you have
So
to
Necrotic
debride.
tissue has to be removed. That is
yes.
what. And the patient has also developed a little amount of ptosis also.
Yes, but on 6 months follow-up, it's completely normal like that. There is no ptosis.
Okay. Thank you.
Thank you.